is going to be one of the final two chapters. This is chapter 11. We did go over chapter 15 in class on the beginning part of the week. So we're going to finish out the recording stuff with chapter 11, which is, again, preventing cardiovascular disease. All right, so let's roll through here and basically get the intro part where we've talked about this in the beginning of class, but I think it's important that it comes back around now, is that the leading cause of death is cardiovascular disease. Beats out cancer. As you can see there, 28.5% of all deaths in the U.S. are caused by cardiovascular disease. All right, and so like it says here, it is a blanket term. There are a bunch of other terms that you can look through that you can see where, CHD, coronary heart disease, stroke, peripheral vascular disease. Then you got congenital heart disease, rheumatic heart disease, atherosclerosis, high blood pressure, and congestive heart failure. All of those make up the whole aspect of CVD. All right, so when we look at cardiovascular disease, it could be a grouping of different issues that have occurred where it does affect either the heart and blood vessels, or just the heart, or just the blood vessels. So you can see here that it can cause complications throughout. But again, very important to understand that it is a leading cause of death. Now, we have risk factors that are going to show up in everything in here, but just understand that there are ways that we can diminish this, but not necessarily wipe it out completely. All right. The most prevalent form of CVD is actually coronary heart disease and stroke. Those are the more common of the two. Technically, with coronary heart disease, what you're going to end up with is plaque buildup, which is going to affect arteries that surround the heart, that provide the heart itself with blood. So you're talking about the coronary arteries that, if they fill up with plaque, they will technically stop the blood from getting to that, and that's where a heart attack occurs, because a heart attack means it's that deadening of that area because it was attacked. When there's no blood supply to it, that means that blood supply cuts it off and it basically dies. And when it dies, it creates that area can no longer be worked, so therefore you end up with a massive condition or a major cardiac event. Stroke is like a brain heart attack where you're basically cutting off blood supply to a specific area or multiple areas of the brain. And that's why most people who have strokes, they don't all have the same type of stroke, or it doesn't affect certain specific areas, because it depends on the area of the brain that the lack of blood flow, meaning the lack of also oxygen not getting to where it needs to be, will deaden the brain in that area. So it is, like I said, it's like a brain heart attack, or like they say here, a brain attack. Stroke, all right. Again, I kind of said it hits everybody differently. It can be a larger or a smaller effect. So again, it does depend on what area of the brain and what function of that area of the brain is going to be affected by that. So risk factors, you can go through them all here. Let's see, some of the main factors that age 55, now it's a higher risk in men. African Americans are at greater risk. This is from years of previous information, but stroke in African Americans, heart conditions in African Americans is actually higher than most other races, and that just, it can be can go through genetic predispositions, and that's really what it comes down to, is that there's that aspect there. These are unchangeable factors, whereas down below you have manageable factors, things like stopping smoking, trying to figure out your blood pressure and make it lower, change the diet in many different ways. That's where next class, when we go into the nutrition class, we will be able to get into that more in a more greater detail. Increasing your physical activity, trying to keep better weight maintenance or lose weight, aiming at cholesterol changes for normal levels for LDLs, HDLs, triglycerides. We'll talk all about those. And then diabetic prevention can all help with stroke diminishment of risk. Not stopping, but diminishing risk. All right. As you can see here, the cardiovascular disease trend has trended downward. In the 60s, you saw this influx, but as you got to the 60s, you started to see that you start to have that decline every 2 decades. So what ends up happening is you have an influx, and then this is where medication gets better. Okay, so you can see here that we're at a lower point than we were in the 40s, but really, what's the quality of life for that person? Are they living in a shell of themselves? Are they doing okay even though they might be on medication or treatment, or are they healing? So I don't think everything there means that we're healthier. I think it just means that we're finding better ways to prevent or to take care of the intermediate outcomes, at that moment. So with coronary heart disease, like we said, it's the most common of the cardiovascular disease, types. So what are we talking about there? Fatty deposits being formed on the actual arteries that restrict blood flow to the heart. Okay, so it does account for about 20% of all deaths and more than half of all deaths from cardiovascular disease. So um, all deaths, meaning that 20% of all deaths that we see, but then it's more than half of the ones that we have from cardiovascular disease. That's what we're talking about. All right. In terms of risk factors, high cholesterol, high blood pressure, obesity, diabetes, and smoking. Very common to, obviously, when we looked at stroke risk factors, very similar. All right. I wouldn't say that there's much difference between that. And then obviously what we're talking about here is I didn't hit on this part here with the bypass surgeries. What you have to do at that point is with a coronary bypass, you have to reroute all of the blood vessel flow to allow for other areas of the heart to not be affected. So you have to be able to do that, and especially when you have that cardiac event, because the heart still needs to function appropriately, and that's what we're saying there. More than 500 coronary bypasses and then 1 million coronary angioplasties are performed every year. So you're talking about angioplasty, or widening out those blood vessels because they were damaged. All right. So with risk factor analysis, we basically are saying here that with coronary heart disease, we have to screen people, to see where they are in terms of their disease risk. The more that these high risk people are, sitting there and not detected is a problem. So we have to be able to educate. At that point, once we educate, we can start doing programs to help them diminish some of those risks. Not, can't necessarily alleviate them all, because as you get older, the damage has been done and the cause of that is really just out there. All right. So we have to be able to analyze, we have to be able to look at it, we have to find intervention strategies, we have to find different ways to change their lifestyle, and that really it becomes challenging because these people have lived that way for so long that it's really a struggle. All right. And now this is just that picture that we saw in terms of when we look at, this is a normal heart on the left, and on the right here, when you see that this is the actual artery that was damaged where the blockage occurs, all right, that's taking all the blood flow to the left ventricle, and it's creating these deadening branches of the arteries that are going to protect that area. So we got to be very, very careful of that because, especially for the left ventricle in particular, because it really can become a problem where that's the major ejection point of your heart. So if that part gets, compromised, then a person is in for a real rude awakening of what really could happen for them for the rest of their life. So therefore, there has to be a way. That's why we'd have bypass to figure out how are we going to get blood to get circulating through the rest of the body. And that might have to be a rerouting of the aorta, or it could be where they have to use the left atrium as the support mechanism. So they have to rework the whole heart. All right. There is a weighing system for risk factors. So when we see here, you can see that unhealthy diet, it has a high amount of risk points. So what we're saying is that if we're seeing people in these realms, any of them, high BMI, the more points you earn, the more at risk you are. So that can be very, very severe. Well, it's a way that as we start, age is one of those inevitable factors. Remember, we said over the age of 55 for certain things. But, if we have a person who had high blood pressure and then all of a sudden they don't, well, their risk factor goes down, or the risk points go down. If they're smokers and they become non-smokers, it still means that there's some damage done, but their risk might go down a little bit as they become healthier. So that's what we're looking for, is to make these changes to try to address the risks that are involved. All right. Sudden cardiac death, we're basically talking about just the heart just stopping. All right. It is the largest cause of natural death in the U.S. Now, again, is it happening to people who are young? It can. Is it happening to older people? Sure. All right. So what we're again going back to that risk factor, we're saying that, again, not smoking, being active, trying to avoid being overweight or obese, all those factors come into play when we talk about sudden cardiac death, because we really need to focus in on all of that and make sure that we're taking care of the things that need to be taken care of. Basically, if you're looking down at that diet, what we're saying there is, really simply put, eat whole foods, avoid the processed stuff, eat more whole foods. That and it really can come down to that, and it will make it a little better in terms of just how people feel and how their risk factor levels go down. Okay. So looking at physical inactivity, what we're seeing here is that all of these, with being inactive, you're going to have, compromised, your body's going to be compromised. All right. So with physical activity and exercise, what we're saying here is you're going to have increased, cardio, endurance. You're going to have good heart function. You're going to improve your cholesterol, HDLs. All right. You're going to lower your LDLs. You can help with diabetic control. You can help with blood pressure, and then total body inflammation. Or an ability to create to increase the C-reactive proteins that are in our system that cause inflammation and disease risk. You can reduce body fat. You can reduce tension, so you're diminishing stress and mental health as well. If you get someone who starts to become a little bit more active, they're a little bit more prone to exercise, they might be more willing to stop smoking because they feel better. And then obviously to try to counteract any personal history, so any genetic predispositions. So that's what we're looking for there. Now, what are we saying here is that, obviously if we can use exercise as a way to be the medication, well, we know that medications can cause secondary complications, all right? Want to make sure that we, avoid the sitting time that we have. Like, I'm sitting down right now doing this lecture, but when I'm done, I'm going to make sure I get up and move around, because it'll probably be around 30 to 45 minutes once everything is said and done, and that's just a long time to be sitting stagnant. So like office workers, get up and move. And that's where I think these types of companies that make you sit for long periods of time, they have to be lenient to the fact that they're not helping with overall health of their employees. All right. And then just overall risk factor management, we're just saying that physical activity is just going to be lowering any sort of it'll lower the risk chance of you having anything to do with cardiovascular disease. All right. So one of the things that we can do, if we're seeing that there's any concerns, or if we just want to be able to have, some sort of testing done, is we're going to look at an EKG, right, an electrocardiogram. And what we're looking at is we're looking to see if there's any arrhythmias, if there's a normal, rhythm of the heart, because we're looking at nervous system impulses and how they're being measured each time your heart pumps or beats. All right. So you can do it at very different time frames. You can do it at rest. You can do it during exercise or high stress levels. That's what a stress EKG is. Or you can do it at recovery after certain things. So it just depends on what you're looking for in terms of electrocardiograms. Now here is a normal EKG. Now if you look and see, there's a bunch of different things. So let's kind of blow this up a little bit and move everything around so you can kind of see where everything is at. All right. So if we're looking at our EKG, what we're saying here is that there's a few different waves that stay pretty consistent. All right. Now this is normal. If you look down here, all right, into these words down here, I'll blow that up a little bit so you can kind of see what we're talking about. Now, when we talk about the P wave is right here. Okay, that P wave is actually what we are talking about is atrial depolarization. Now, the word depolarization means excitation. So what's going to happen is you're going to have nervous system impulses that are going to fire off the atrium to send blood from the left and right, or the right and left atrium, down to the ventricles. All right. So that's where that first initial indicator is for the P wave. All right. Now, when you get into what we call the QRS segment or complex, that is actually ventricular depolarization. So what happens is you have atrial depolarization, a slight pause. That's why you have like the lub dub, all right, of the heart. So that's your, your lub, this is your dub. The QRS is actually what we would call ventricular depolarization. So if the P wave was atrial, the QRS is ventricular excitation or ventricular depolarization, or the ventricles are going to contract because the nervous system is going to send impulses to those muscles so that the right and left ventricles will send blood to the correct location. Right ventricle to the heart, the right ventricle to the lungs, and then the left ventricle to the aorta, and then to the rest of the body. And then again, you have this slight pause, and then you're going to have one more wave, and that's your T wave. That's ventricular repolarization, and that's where you're going to have that relaxation of the ventricles. All right, repolarization meaning more relaxation. So that's more of when the diastolic components come into play. All right, so again, atrial depolarization, ventricular depolarization, and ventricular repolarization. And that's what we're really looking for in that manner, is that you have these different waves that occur, and that's when you have different nervous system impulse to either excite or relax. And we obviously want to excite because we want blood to get sent to the correct areas of the heart. Now, when you look here, this is an abnormal. You can see here that there's a massive difference between the QRS, all right, on one versus the other. And now you're having a depressed, what we call an ST, and that just means that you're basically not being able to get the heart to get back to that true, homeostatic kind of region where that, the T wave for repolarization is not there. Okay. So we have to be very careful to understand that, what looks normal and what looks abnormal. And with proper EKG training, which if you're going to be an exercise physiologist, this is going to be something that you're going to have to understand how to read. These are the types of things that will show like a complication in a person. And if they're showing this on a treadmill while they're doing a specific test, this is where we would have to stop them, terminate them, and then get them to rest and recover. And then we would have to get the doctor involved to figure out what it is that can be changed. Okay. So that's detecting. Now, what are we looking at in terms of cholesterol profiles? Or as we would say, blood lipid panel profiles. Well, these are some of the things that you're going to find in those panels: HDLs, LDLs, VLDLs, chylomicrons. Okay, those are all part of what is made up of what your blood lipids are, your blood fats that are rolling through the system. Now, they're called lipoproteins, so they're a protein fat. Okay, that's what we're saying here, is that they have they're protein molecules with a fat base. Okay, just of different levels and densities. Okay. So with abnormal cholesterol profiles, we can end up with atherosclerosis, which is, again, plaque buildup on the walls of arteries. Now, arteries have high velocity, meaning that when blood is ejected out of the heart through the left ventricle, there's a high trajectory rate or velocity rate of that blood, and it has to stay up. That's why you have blood pressure. That pressure has to stay up so that it can flow through the whole body. Well, if you're under an atherosclerotic, type of way, what happens is that blood pressure has to go up because you're starting to constrict the area or the surface area of that vessel, meaning you have to push harder, more pressure to get blood to flow where it's got to go. Okay, but again, if we have an atherosclerotic issue in the coronary arteries of the heart, that's where we talked about heart attacks happening. All right. Also, you can have symptoms like with atherosclerosis, you can you end up with symptoms like what we call angina pectoris, which is basically pain of the chest. All right, and that usually starts, like it says there, it usually starts occurring when you have about a 75% blockage, and that's usually a good indicator to we have a problem. Okay. So there's your, going from a healthy artery to now some plaque buildup to a little bit more. And so again, normal pressure, increased blood pressure, more increased blood pressure, and then very high blood pressure because now you're trying to push small amounts of blood through a really tight area. All right, so it can be very, very scary for someone because they don't even know this is happening. Okay, not until it's either too late or if they go for a regular checkup, it gets shown. Okay. So one of the things that we're seeing here with types of types of issues that we have is relative risk of those with different levels of omega-3 fatty acids. And what we're seeing here is that, the higher the percentage of fat, omega-3 fatty acids in the system, the less risk we have of having an incident, okay, or with having sudden cardiac death. So again, I'm not saying go on a fish oil regimen because it might not be in your cards, but what we're saying here is that if we have the proper amount of fatty acids that are going through our system in the right quantities, well, then we'll be able to create less inflammation of the body, and then ultimately create a better circulation of blood and just overall well-being. Okay. So here what we're seeing too is when you have high levels of cholesterol, high levels of C-reactive protein, which was what I was talking about earlier, where if you have high levels of C-reactive protein, that's usually a sign of inflammation in your system. Well, combining high levels of those plus cholesterol means that you're in a higher risk for, cardiovascular risk. So very, very scary. Needs to definitely be controlled. And we can determine C-reactive protein counts in your blood. Okay, and then they'll show. So this chart here, what you need to pay attention to are all the desirables. So with total cholesterol, we want to be in this first region here, where we want to have under 200 milligrams per deciliter of blood total cholesterol, which is a combination of all the cholesterols. For LDLs, it's optimal to be under 100 milligrams per deciliter. And then for LDLs, what we want for low risk is we actually want to have higher numbers. So we actually want to have a higher amount of HDLs compared to LDLs, or a better ratio, okay? So with HDL cholesterols, it's 60 milligrams per deciliter or above, all right? Whereas LDLs, we want below 100, okay? That's what we need to pay attention to. So you might see test questions based on that. As far as, again, going through with cholesterol, we talked about it. Well, with saturated fats, trans fatty acids, which we're going to talk about next class, all those can help in increasing cholesterol count. Now, there's been some, a lot of studies recently, because everybody is so afraid of all of this stuff, that saturated fat may not be as bad for us as we thought. But again, you got to be careful where that saturated fat is coming from. Obviously, with saturated fat, it is an animal-based, fat. It comes from animals, all right? And then trans fats are typically going to be found in, more processed foods. They're going to be additives, all right? Whereas if, with omega-3s, which we talked about before, they can decrease what we call triglyceride levels, or storage, or free-floating fat in our blood, all right? And that's typically found in fish, but what that can do is it can decrease triglycerides and then increase HDLs, which is very, very important. So again, why trans fats are really, needing to be avoided is because they lower HDLs, they lower the good cholesterol, they increase the, not so good, or LDL, lower density lipoproteins, and then they increase triglycerides. So again, are we eating fried? Are we, packaged, processed? Now baked, it just depends on what it is. Now, baked chicken, not going to raise trans fats. A baked potato, not going to raise trans fats. That's what, but again, it's what is baked. It's usually typically processed baked. So with LDLs, what we're saying here is we can make dietary changes. We can lose body fat. We can do more exercise. If you have to, the last resort obviously would be the last two there, taking medications or, specific drug therapies if diet's not making that necessary change, okay? So if you're a person who is afraid of your LDLs and your blood samples that you give, and the doctor feels as though it's, hasn't come down in the past 3 years, well then, there's really that's a scare. And that means that there needs to be a change in what you're doing, and that's probably going to be medication based. All right. With saturated fats, what we're saying here is that, we want to find a way to replace a lot of the saturated fats with other things, other things like poly or monounsaturated fats, all right, which are more of the healthier fats that are, found in, plant-based things and things in such a manner, like oils, stuff like that. Now, nuts, seeds, legumes, all right, but all that is part of next class. But what we're saying here is that just be aware of how much saturated fat you are taking in, because the more you have saturated fats, the more apt you're probably taking in more refined sugars, simple carbohydrates that can change what your diet really is. And that's where we start to see that shift where, you start going from healthy to unhealthy. Elevated triglycerides, well, we're seeing here again more process-based things and alcohol. So trying to find ways to avoid those processed things. Try to if you're a drinker, minimize how much alcohol you drink. Don't cut it all the way out because that's hard to do right off the cuff. All right. With triglycerides, trying to bring down fat consumption. Try quit smoking and then losing weight if possible. And so with your triglycerides, again, going with those the desirable numbers below 150 milligrams per deciliter. So below 150. And then, here we have different types of cholesterol-lowering medications. We don't get big into that because, one of the things that we have to realize is that with medications, that's outside of a little bit of our scope. But if we know that if you get like a health history, questionnaire given back to you and you see that they're on a cholesterol-lowering medication, it's going to be in your best interest to research what it is and see what it does, okay? Because maybe it'll have an interaction with something you may be doing, all right? So, but again, medications typically want to be last resort, but make sure you know what they are and what they do, because it'll help you with working with your individuals. Homocysteine, what we call that is an intermediate amino acid. This is a really big player in, building proteins, but also with cellular metabolism. So with burning. So the other thing is that with higher homocysteine levels, what you're saying here is that you're standing a greater chance of plaque development. All right. So it really can become a problem where this can be a precursor with if you start to see higher levels of homocysteine, that means that you're probably ending up developing plaque on your arteries in that moment. So you have to make sure you're paying attention to that. So get your blood vessels looked at. Try to see if you can get an ultrasound of your blood vessels. See if you can see any imaging where if you're starting to see a constricting of those blood vessels, then maybe the blood is telling you that that's happening. So you just got to be aware. Okay. We don't really get into this in terms of testing, but again, your desirable is less than 9 micromoles per liter of blood, which is a small amount, but it's enough that it's going to cause complications within your blood vessels. There's your C-reactive protein, all right, again, showing more inflammatory markers, but again, can be, high levels of C-reactive protein can be a precursor to heart attacks, so you got to be aware of that. Omega-3s, or that omega-3 type of fatty acid actually can help diminish the cause of inflammation. So it can almost kind of like antioxidants help with free radicals. Omega-3s can help with C-reactive protein buildup. Okay. Diabetes, now again with cholesterol problems, it can be a start besides obviously exercise and lack of movement. But diabetes can be caused based off of cholesterol profiles because what you're saying here is that cholesterol is a sign of poor diet. Well, poor diet and exercise, there you go. Okay, so what is diabetes really? It's a blood glucose concern, where it's blood glucose is not regulated very well. So it depends on what type you have, where insulin can or will not be, can be appropriate or will not be appropriate for what you're doing. So I think it's really scary that one where it says almost half of the U.S. population has diabetes or is predisposition to diabetes. That's alarming. That's a really alarming thing to think about. So there's your two types. Well, there's a few others as well. So we'll add a little bit to that. Just so that we can kind of be a little bit more aware of what also is out there. All right, so when we look at everything, you have type 1 diabetes, you have type 2 diabetes, you have pre-diabetic nature, and then you also have gestational or pregnancy-based. All right, so with type 1 diabetes, what we're saying here is that you are also known as, this could be juvenile, and this type 2 could be what we call adult onset. All right. Now with type 1 diabetes, we are basically saying here that you could be born with it all the way up to the age of 10, and then you're pretty much going to have it for the rest of your life. It's insulin dependent, meaning that if you put insulin into your system, it will react and drop blood sugar, okay, or blood glucose. Type 2 diabetes is usually developed during adult stages because of lack of exercise, poor health, etc. But what we're seeing is that a lot of younger children are even starting to show signs of type 2 diabetes, which is very scary because that's not supposed to happen. Now, it's non-insulin dependent, meaning that insulin, for majority of cases, will not do the job. For some cases it will, but for majority of type 2 diabetics, it's not going to. And what you're going to end up being on is a medication to help with blood glucose getting moved and lowered. Okay? Pre-diabetic means that you're not in a normal category, you're not in a type 2 diabetic category. What it means is that you are in that in-between stage, which means that you're at risk of developing diabetes. And then gestational is really pregnancy-based diabetes, where a female can develop it during pregnancy, but it's not guaranteed to stay with that female after she has had the child. Okay. Let's see if they give you the levels here. That's blood glucose. So what I'll do is I'll give you the levels so that you can see. So with type 1 diabetes, for type 2 diabetes, what we're saying here is that it's greater than, okay, what we're saying here is that for type 2 diabetes, it's greater than or equal to 125 milligrams per deciliter, meaning that you're basically having a level that's that high, okay? Meaning that when you actually are measured taking a blood glucose test, you are going to measure in that category. So it really becomes a problem where you're getting these numbers back, and what we're saying here is that it really can become a problem, because if you're that high, you need to look at what it is. So usually you do an 8-hour fasted test, and then what happens is you get these numbers, and it'll say, okay, well, this is what you're at. Well, you're not going to just do it that one time and say, oh, you're diabetic. Okay, you're going to have to follow up for a few months to see where those levels are, or have to start checking yourself. Okay. And usually it's usually two separate occasions a lot of times where they like to see that. If you come back for a follow-up and you're still above that 125, it becomes a problem. Now, pre-diabetic is the range of 100 to 125. Okay, that's usually pre-diabetic, which means risk factor. All right, and then normal levels are less than 100 milligrams per deciliter. Okay, so what we're saying there is that under 100 is normal. 100 to 125 is typically considered pre-diabetic, and then anything above, it should actually, we'll just say greater than 125. So it would be greater than or equal to 126, but anything greater than 125. And you can have people that have 2s, 3s, 400s in those test scores. So you can't be alarmed when you see it. Just understand that it's very severe, and they desperately need the medication or insulin or some help with lifestyle changes. All right. So diabetic management is going to be critical. Gotta get them to lower their blood glucose. We got to get them to become more what we call insulin sensitive and less insulin resistant. Okay. So therefore, with exercise, we want to do both aerobic exercise and strength training, because that means working muscles will will take in blood glucose better. All right, and you'll start to see a change in the insulin sensitivity of it being used. All right. What you can also do is when you're talking about diabetics and their diets, we want to get them on a lower glycemic index based food source. The higher the glycemic index of a food, the more sugar it contains, or what we'd say more simple sugars it contains. All right, so like table sugar is the high, probably one of the highest besides straight glucose that you can have, where table sugar has a severely high glycemic index, which means that it raises blood sugar very quickly, and insulin has to be released very quickly to counteract that. All right. So, we have to be aware of that. Now, besides a fasting test, we can also do what we call a hemoglobin A1C, or sometimes you might see HbA1c test, and that's the same, it means the same thing, but really with that, you're looking at numbers usually above 6.5% is really what can be really scary for them. All right. So if it's below 6.5, that means that you're in a normal range. Above 6.5, that means you may be considered diabetic. All right. But again, it's measuring the amount of what we would call glycosylated. It's glycosylated hemoglobin, meaning how much of the hemoglobin is saturated with glucose. Okay. And then metabolic syndrome, what we're saying here is that's a conglomerate of different aspects, meaning that it could be you're diabetic, you have high blood pressure, you're inactive, all right? It could be any of those things that it's usually more than one issue that is a problem with metabolic syndrome, all right? And again, you're going to treat it very similarly to how you would treat diabetics or those with coronary heart disease. But it's usually it's multiple issues that a person has, and typically, usually, it's diabetes and some form of heart condition. Usually, it's hypertension. All right, there's your hypertension. What are we looking at in terms of ideal 120/80 or below? But again, it's that's also been lowered. I think 115/75. I've heard. Trying to have your diastolic or the bottom number as low as possible. Okay, that's really what we want to pay attention to there. So there's your elevated, your stage 1, stage 2 hypertensive crisis. So if you're in any of these regions, that's down here, that's scary. Okay, that really starts to show that you're becoming more hypertensive, but again, on multiple occasions. Again, under 120, under 80. So if you're in stage 1 hypertension, if your blood pressure is 142/81, what we're saying, or actually if we said it was 140, 141/82, what we're saying there is that that's still in that that stage 1 hypertensive range. 82 still in above that hypertensive range. So it has to be and or, okay? If you're 167/83, that's still stage 2 hypertension because it's one of the two. It's either systolic or diastolic or both that have to be in those ranges. All right, so again, the silent killer, different ways that we can try to treat that. Again, exercise, being very cautious though if they are hypertensive, because we can't raise we can't get them to become hypertensive because of exercise. We got to be very cautious of it until they start to react and start making changes to their system. Trying to avoid fat, not avoiding, but trying to minimize, salt and fat intake. Be careful of your protein. Don't diminish your protein. And they say flaxseed consumption, but be very careful of that. You want to make sure you talk to a dietitian if that's the case. Lower alcohol and caffeine intakes can help, because caffeine helps raise blood pressure during those times. And then try to stop smoking and try to manage your stress better. All right. There has been some research recently that shows that sodium is not necessarily the main cause, but don't underestimate that. All right. So if you're a person who has hypertension, but one of the main, you're not stressed, there's, your weight is good, you have good, proper body composition, maybe it is sodium, maybe it's just genetic. All right. But making sure that, you're careful of your sodium to potassium ratio, because that can alter you can go hypertensive or hypotensive depending upon everything. All right. So, again, just making sure you're monitoring your blood pressure. Try to avoid things that are going to be very high in blood pressure. They're going to raise it too much initially, and then as they become more tolerant of it, we can start making more long-term changes. We can start to make changes to make them, a little bit more intense, so that they can, be able to make those changes accordingly. And then we've already talked about, a lot of this stuff, but it's very similar. But, these are the things that we saw previously, but very similar for blood pressure management. Okay. So, one of the things we still have to be aware of too, excessive body fat. Like it says, an independent risk factor. If you have excessive body fat, what we're saying is that it can increase the risk of coronary heart disease. Pretty straightforward. All right. So, paying attention to the amount of total fat you have in your system. Now, visceral fat, we talked about it earlier in our class, where that's the fat that's surrounding the major organs. So that's the more, that can be the more dangerous fat, especially if it's in the belly. All right. So what we're saying here is that, if we're in these categories, look what happens if you're big and you're inactive. You have almost a three times higher chance of developing some sort of issue with coronary heart disease, and then heart failure risk. So that's pretty scary. If you're lean and inactive, again, if you're lean, what are we saying is lean? It's a BMI below 25. All right. So we're saying if we're lean and inactive, it's still a risk, but not as severe as it could be. So, again, we said tobacco use, trying to avoid, having, damaged arteries, damaged alveoli, which can pass everything from the lungs to the blood vessels or in and out, oxygen in, CO2 out. You're talking about oxygen carrying capacity, so your red blood cells aren't doing what they're supposed to be doing. You have problems with increased heart rate and blood pressure. So you can see that there's a lot of different things, and then decreased good cholesterols or HDLs. So, quitting, there's still some damage, but you can try to start reversing that damage as best you can, even though some of it is just going to be unreversible. But again, still want to try to maintain health as much as possible. So tension and stress, we kind of talked in chapter 10 about, stress management routines. So we got to avoid that stress and that constant, what we call parasympathetic state, or being excited. Okay. Chronic stress can do that. It can cause those negative aspects down here, which can also lead to a heart attack if not taken care of, or other actual problems with the body. So again, genetics, they are what they are. Unfortunately, genetics can cause you to have problems that a good lifestyle has given you, but genetics can kind of bring you in a different way. I'll give you an example. For whatever reason, I was diagnosed with high blood pressure. I'm a very active and healthy person. I eat well, but the problem is that I do have a family history of blood pressure. So I have to be very careful of that and try to just maintain myself as best I can to avoid having any further complications. But unfortunately, because the doctors felt it was necessary, I am on a medication for that. So the goal here is to see, to get my blood pressure down low so that we can come off of that. So we'll see what happens. But, again, family history, it can be anything with diabetes. Diabetes is not always genetic, but it can have genetic predispositions. So you just got to be very careful of what your background is and always stay on top of it. Age, above 55 for women, above 45 for males, and that's usually your risk factor. Whereas, as you start getting above 45 for men, your risk factors increase for getting, some sort of condition. For women, it's 55. So take that, that's a blessing. All right. And then, obviously, what are we trying to do here with, with these risk reductions? Just stay consistent, stay persistent. Try to keep up that effort, that willpower, that commitment, and then try to make everything a lifestyle. One and done doesn't help anybody. You're not a college basketball player. But what you're saying here is you want it to be a lifetime of activity and good eating and good decision making and trying to have stress reduction and body composition. So all of that comes into play. So we got to be very aware of that when we're working with our people, when we're working with ourselves, and just trying to create this overall total high quality of living that can help with a high quantity of life. All right. So chapter 11, pretty in depth. Pay attention to those numbers for your testing, and I think you'll be all set with that. So I hope you guys have a good weekend, and we hope to hear from you soon. Take care.